Welcome to another exploration from Optic Surgeon, the Ophthalmology podcast. Today we're diving straight into double vision, also known as diplopia. We'll be looking at what can cause this really fascinating and sometimes, frankly, unsettling experience of seeing two images instead of one.
Yeah, it's definitely more than just a visual oddity, isn't it? Diplopia, it often tells you something fundamental about how your eyes and brain are coordinating, or maybe not coordinating, has been disrupted. We'll be digging into some of the key reasons this happens and, what it might mean.
Okay, so the basic idea, diplopia, seeing double. Now, it's interesting, this can happen in just one eye, that's monocular diplopia. Or it might vanish completely when you cover one eye, that's the binocular type. And today we're really focusing on the underlying causes and the implications, right?
Exactly. And it's a sheer variety of things that can trigger it that's striking, particularly with binocular diplopia, the fact that closing one eye makes it go away. That almost always points to an alignment problem. The eyes just aren't pointing at the exact same spot together. It really highlights the incredible precision needed for us to see just one clear image.
And this is where it gets really interesting. There are quite a few neurological connections mentioned in the sources we looked at. Cavernous sinus syndromes, for example. What's the story there?
Right. Think of the cavernous sinus like a busy junction box right behind your eye.
Yeah.
Several crucial nerves that control eye movements pass through this small space. So if something goes wrong in there, maybe inflammation, a blood clot, even a tumor, it can easily affect multiple nerves at once. The result: the eyes don't track together properly, and bang, double vision. It shows how interconnected everything is back there.
Okay, a problem in one small area affecting multiple nerve functions. And then there's internuclear ophthalmoplegia, INO. Sounds a bit technical. Can you break that down?
Yeah, it does sound complex. So imagine there's a specific communication pathway in your brainstem called the MLF, the medial longitudinal fasciculus. Its job is to make sure both eyes move together smoothly when you look side to side. Now, if that pathway gets damaged maybe from MS, a small stroke, something like that, one eye might really struggle to turn inward towards the nose, and the other eye, the one looking outward, might show a kind of jerky movement, nystagmus. That lack of coordination causes the diplopia. It's a very specific wiring problem.
Oh, okay. So a communication breakdown for side-to-side movements. Makes sense.
Exactly. And then you've got the individual nerves themselves, the third, fourth, and sixth cranial nerves. Palsies, or weaknesses of these, are, well, very common causes of double vision. And the range of things that can cause these palsies is huge. It could be something relatively common, like a small vessel problem linked to diabetes or high blood pressure, cutting off the nerve's blood supply. Or it could be trauma, congenital issues someone's had since birth, inflammation, demyelinating disease like MS again, or even pressure from, say, a tumor or hydrocephalus.
Wow, so even just problems with the tiny blood vessels feeding these nerves can cause double vision.
Absolutely. These nerves need a constant, healthy blood supply. And, there's an interesting point about telling congenital palsies apart from acquired ones. Apparently, you can sometimes get a clue by testing the eye's vertical fusional amplitude, basically, how well the brain can merge slightly different vertical images. It's a subtle diagnostic hint.
That's quite specific.
Yeah.
Now, myasthenia gravis also comes up. That's a neuromuscular junction disorder, right? Affects muscles.
Yes, precisely. Myasthenia gravis messes with the signal transmission between the nerve ending and the muscle itself. The key thing here is that it causes muscle weakness that fluctuates. It gets worse with activity or later in the day. And because the eye muscles require such fine, constant control, double vision and droopy eyelids are often, very early signs. And there are specific diagnostic clues, like the weakness improving temporarily if you put ice over the eyelid, or with a drug test using edrophonium.
Interesting. And what about CPEO, chronic progressive external ophthalmoplegia? That sounds like more of a slow burn.
That's right. CPEO is different. It involves a very gradual, progressive weakening and limitation of eye movements, usually affecting both eyes over years. But interestingly, even though the eyes might not move much, double vision often isn't the main complaint, or might even be absent. This is likely because the limitation often affects both eyes quite symmetrically, so they tend to stay relatively aligned despite the poor movement. The pupils are usually fine too.
Okay, so limited movement, but potentially no double vision because it's symmetrical. What about increased pressure inside the skull? How does that fit in?
Increased intracranial pressure. Well, that pressure can put a squeeze on certain cranial nerves. The sixth nerve, which moves the eye outwards, is particularly susceptible because it has a very long path inside the skull. So high pressure can cause a sixth nerve palsy, making the eye turn inwards, and that leads to horizontal double vision. It's a non-localizing sign, meaning it tells you the pressure is high, but not necessarily where the problem is.
Got it. And we also mentioned giant cell arteritis, GCA. Why is that such a big deal, especially if an older person suddenly sees double?
GCA is a serious inflammation of medium and large arteries. If someone, usually over 50, develops sudden double vision, particularly if they also have symptoms like a new headache, jaw pain when chewing, scalp tenderness, you absolutely have to consider GCA. It's an emergency because it can quickly lead to irreversible vision loss, like from an arteritic ischemic optic neuropathy, if it's not treated fast with steroids. The diplopia could be from ischemia affecting the eye muscles or the nerves. It's a major red flag.
Definitely something to take very seriously. Okay, and one more on the neurological side. Vertebrobasilar artery insufficiency. Sounds like blood flow issues to the back of the brain.
Exactly. Problems with blood flow in the arteries supplying the brainstem and cerebellum. This can cause transient, temporary neurological symptoms. These might include things like dizziness, vertigo, difficulty speaking or swallowing, weakness, and yes, sometimes brief episodes of blurred vision or even fleeting double vision. It's like a mini stroke or TIA in that area.
So, quite a list of neurological possibilities. Let's shift focus now to problems more directly within the eye socket itself, orbital issues. Trauma seems like an obvious one.
Yeah, orbital trauma, especially a blowout fracture where the floor or medial wall of the orbit breaks often from, say, a fist or a ball hitting the eye. This can actually trap one of the eye muscles, usually the inferior rectus, in the fracture site. When that muscle is trapped, it can't move properly, causing restriction and definite double vision, especially when trying to look in certain directions, like upwards. And there's a critical point here. Sometimes, if that muscle entrapment is severe, it can trigger something called the oculocardiac reflex.
Oculocardiac reflex, so an eye injury affecting the heart.
It sounds surprising, but yes. Traction on the eye muscles can stimulate the vagus nerve, leading to nausea, vomiting, and crucially, a slowed heart rate, bradycardia. If that reflex is happening, it can be a reason for needing more urgent surgical repair to release the trapped muscle.
Wow, okay. Orbital tumors are also mentioned. How do they typically cause diplopia?
Well, a growing mass within the confined space of the orbit can physically push the eyeball out of its normal position. This can cause proptosis, bulging of the eye, but also displacement, shifting it up, down, or sideways. That physical shift disrupts the alignment between the two eyes, leading to double vision. The type of tumor varies widely, especially between children and adults. And imaging like CT or MRI is key.
And what about this IOIS, idiopathic orbital inflammatory syndrome? Sounds like the orbit just gets inflamed for no clear reason.
Pretty much. It's an inflammation of the orbital tissues, could be the fat, the muscles, the lacrimal gland, without an identifiable infection or systemic cause. It's thought to be immune-related. If the inflammation involves the eye muscles, called myositis, it causes pain, swelling, and restricts movement, which again leads to double vision.
Okay. Moving slightly away from the orbit structure itself, thyroid eye disease comes up frequently, often linked with Graves' disease.
Yes, very commonly associated with Graves, an autoimmune thyroid condition. Thyroid eye disease involves inflammation and swelling of the eye muscles and orbital fat. The muscles, particularly the inferior and medial rectus, can become thickened and fibrotic, restricting movement. This classically causes problems looking up or out, leading to vertical or horizontal diplopia. You also often see other signs like eyelid retraction where the lid sits too high, proptosis, and maybe redness and swelling around the eyes.
Right, the characteristic thyroid stare.
Yeah.
Our sources also briefly touched on double vision happening after eye surgery.
Yeah, it's less common, but definitely possible. Any surgery that involves manipulating the eye muscles, like strabismus surgery, or even procedures near the muscles, like retinal detachment repair, or sometimes even cataract surgery if there are complications with anesthesia, could potentially cause temporary or rarely persistent double vision. It might be due to direct muscle damage, nerve damage, or just swelling and inflammation affecting alignment as things heal.
So it's crystal clear that seeing double isn't just some minor inconvenience. It's a symptom that really demands a proper workup to find the root cause.
Absolutely. The evaluation has to start with a really careful history. When did it start? Was it sudden or gradual? Is it constant, or does it come and go? Worse at certain times of day? Which direction of gaze makes it worse? Any associated pain, headache, weakness, numbness, past medical history, especially things like diabetes, thyroid problems, any trauma.
All those details are crucial clues, I imagine. in the eye exam itself?
Essential. A thorough check of visual acuity. Pupils looking for differences in size or reaction, which can point to nerve issues, and then a very detailed assessment of ocular motility, checking how each eye moves individually and how they move together in all directions of gaze. We look for limitations, overactions, misalignments. We also often measure the misalignment using prisms or tests like the cover test, or as mentioned, maybe something like the double Maddox rod test for torsional or complex misalignments.
And if the history and the eye exam don't immediately point to an obvious cause?
That's when neuroimaging usually comes in. An MRI or CT scan of the brain and orbits is often needed. This helps look for strokes, tumors, inflammation, nerve issues, sinus problems, orbital fractures, thyroid eye disease, changes all those potential structural causes we've discussed. Especially critical if a neurological cause is suspected or the diplopia isn't clearly isolated to just an eye muscle issue. Sometimes blood tests are needed too, checking for things like thyroid function, acetylcholine receptor antibodies for myasthenia, or inflammatory markers like ESR and CRP if GCA is suspected.
So the bottom line really is, if you suddenly start seeing double, don't just wait for it to go away. It could be signaling anything from a relatively manageable nerve issue to something quite serious requiring urgent treatment.
It's exactly it. Diplopia is a significant symptom. It warrants a prompt and thorough evaluation to figure out why it's happening and get the right management plan in place.
That's a wrap for today's episode. I hope it brought some clarity to your clinical thinking. Until next time, stay focused, keep learning, and don't forget to subscribe for future insights.